MHG, under the guidance of Dr. M.B. Agarwal, in last 2 years has given an opportunity to have the global experts connect with the experts from India and simultaneously disseminate the learnings to many, many clinicians across the globe, which is definitely helping improve hematology outcomes. Today, we have one of the global experts on CAR-T, our eminent guest speaker, Dr. Loreto. Good morning, doctor, and welcome to this forum. I also extend my warm welcome to our eminent faculty members who have joined us from almost every part of India and will be discussing with Dr. Loreto post our session. I also welcome virtual delegates who have joined us for today's webinar from not just India, but across the globe. Now, a special welcome to the person who has got everyone together for today's webinar, Professor Dr. M.B. Agarwal. Sir will also moderate today's discussion post ma'am's session. I have the privilege today to introduce him. Professor Dr. M.B. Agarwal needs no introduction, but I'll take this opportunity to introduce her. He is presently the head of Department of Hematology at Bombay Hospital Institute of Medical Sciences at Mumbai, and also the director of the Hematology Center located at Dadar in Mumbai. He also acts as a consultant hematologist at a number of hospitals in Mumbai, including the Lilavati Hospital and Breach Candy. Sir has held a number of important positions, some of which are past President, Indian Society of Hematology and Transfusion Medicine, President, Mumbai Hematology Group, Selection Committee at Department of Pathology at Tata Memorial Hospital, Mumbai. A career spanned over 4 decades has not just helped patients in India get better, but he has also inspired many young clinicians to take up hematology and has always taken lead to disseminate hematology updates by bringing the eminent and expert group together. Thank you, sir, for your contribution and all your efforts for these credentials. Over to you, sir, to take this program forward.
Thank you, Ashish. Good evening to one and all from India, and good morning, good afternoon from those who are logged in from the rest of the world. We today have delegates from almost 25 countries who have logged in to listen to our guest speaker. Today our guest speaker is Dr. Loretta J. Nestopil from MD Anderson. She'll be speaking on CAR-T therapy in lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and the team from Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Loretta Nestopil. All our discussants who are themselves eminent hematologists or medical oncologists, and you participants for sparing your Saturday evening from India and any other timing from the rest of the world. Do remember to visit the website of Mumbai Hematology Group. It is simple to remember, www.mhg, that is Mumbai Hematology Group India.com, and you will have at your screen all the future academic activities that this group does. Virtually every Saturday evening and Sunday morning, we have international guest speakers speaking to us, and these have been very, very informative webinars. Tomorrow morning, we have Dr. Kunal Sehgal speaking to us about approach to thrombocytopenia and platelet count, practical tips and troubleshooters at 11:30 a.m. Our discussants, they have been put up alphabetically in this list. To introduce them briefly, Dr. Anant Gokar from TMC Mumbai, Dr. Chirag Shah from Apollo Hospital, Ahmedabad, Dr. Dharma Chaudhary from BLK Max Super Specialty, Delhi, Dr. Surgeon Commander Gaurav Narula from Tata Memorial Center, Institute, Mumbai, Dr. Hari Menon from St. John Medical College, Bangalore, Dr. Mobin Paul from Rajagiri Hospital, Kochi, Dr. N. Aditya Murli from Esther Hospital, Bangalore, Professor Dr. Colonel Prakash Chitalkar from Sri Aurobindo Medical College and PG student, Indore, Dr. Ruchira Mishra from SRCC Children Hospital, Mumbai, Dr. Sharad Damodar from Majumdar Shah Medical Center, Bangalore, Dr. Shweta Bansal from HN Reliance Foundation Hospital, Mumbai, and Dr. Vikas Talreja from Regency Hospital, Kanpur. And now it's my proud privilege to introduce our guest speaker for the day. She has been to Mumbai, she has been to India in past. She's also helped us by webinars in these last 2.5 years. She is Associate Professor, Section Chief, Indolent Lymphoma, Section Chief, New Drug Development, Department, Lymphoma Myeloma at University of Texas, MD Anderson Cancer Center. She's a clinical researcher with focus on lymphoma epidemiology and outcomes, especially indolent lymphomas. The goal of her research is to identify risk factors associated with lymphomas and eliminate disparities in outcomes to improve survivals of all patients with lymphomas. She's actively involved in early phase drug development as well as immune therapy, including CAR-T in indolent lymphomas. She's also actively exploring predictive biomarkers for therapy in lymphoma. So I invite her to give the lecture of CAR-T therapy in lymphomas now. Thank you. Over to you.
Thank you. I really appreciate the opportunity to share just some insights that we've gained over the last few years as we've been now using CAR-T in the clinic since late 2018. And so really, I'm going to walk you through the pivotal studies that led to FDA approval of CAR-T, share some of our real world experience, and kind of end with future directions and where things are moving next. These are my disclosures. SCHOLAR-1 was a retrospective study that established the outcomes for patients with large cell lymphoma prior to the introduction of CAR-T into the treatment landscape. So this was an endeavor with Mayo, MD Anderson, and then 2 prospective European studies establishing the outcomes for patients, again, prior to the introduction of novel therapies. And you can see that CR rates were quite low with mostly chemotherapy-based approaches. Median overall survival was only 6 months. And these included, again, patients had access to trials, including at our center. And until we saw the introduction of cellular therapy into this treatment landscape, the outcomes were very poor for the vast majority of patients. There are 3 FDA-approved CAR T-cell therapies in the US for treatment of large cell lymphoma, and they do vary in terms of the construct, the manufacturing process, and how we deliver the care, including the dosing of lymphocyte depleting chemotherapy. But currently, if we wish to pursue a commercial product, the collecting of the cells is tied to the manufacturing. So this is not a situation where we might collect cells and bank them and then use them at a later time. There, again, are differences in whether a retrovirus or a lentivirus is utilized to manufacture the CAR. They all have the same extracellular domain, but they do vary in their transmembrane hinge region. And probably even more importantly, they vary in their intracellular signaling domains, which probably results in differences in the rates of acute toxicity, specifically CRS and ICANS. I'll walk you through those pivotal studies and results. The time from collection of cells to infusion of cells varies quite dramatically, with the shortest times with axi-cell and the longer times with tisa-cel and lyso-cel. The pivotal phase 1/2 study of ZUMA-1, which was led by Dr. Satva Nilapu at our center, resulted in the approval of axi-cell for the treatment of relapsed refractory large cell lymphoma, first approved in that 3rd line or later setting based off of this trial. This was conducted in patients with either primary refractory disease who never achieved chemosensitivity, therefore never went forward with high-dose therapy auto transplant, or those that progressed within 12 months of auto transplant. This also allowed for transformed follicular primary mediastinal large B-cell lymphoma. And you can see the vast majority of patients had 3 or more prior lines of treatment. Over 2/3 were refractory to their last treatment. And despite this, with a single infusion of axi-cell, we see objective response rates of 83% and a complete response rate of 58%. But even more importantly, in my opinion, is this plateauing of these progression-free survival curves. We do see the majority of patients that fail to respond or respond and lose their response occurring within the first 3 months. But then you tend to see a pretty stabilization of those curve, suggesting that the majority of patients who are in a complete response at 3 months remain in a complete response for years to come. Tisacel or tisagenlecleucel is also a CD19-directed autocar. It has a 4BB construct, and based off of the phase 1/2 study of Juliet, was approved for the treatment of large cell lymphoma or transformed follicular. It was studied in a slightly different patient population. For instance, they excluded primary mediastinal patients, and this had a larger proportion of patients who were relapsed and not necessarily refractory. I can see just over half of the Juliet study was refractory to their prior line of therapy. The objective response rates are listed here. There were differences in the grading of the acute toxicity, including CRS and ICANS. So you can't compare the rates of CRS or neurotoxicity across these studies, at least in terms of how they reported them for the studies. But at least in my experience, the 4BB constructs have less in the way of grade 3 or higher neurotoxicity and lower rates of CRS. Lysocell, another 4BB construct, was FDA approved in the third line or later setting initially based off of the Transcend study. Now, this is one of the larger of the 3 trials. It also had a broader eligibility criteria in terms of lymphoma subtypes. So it included transformed disease from other indolent histologies, not just follicular. And the eligibility criteria were much more generous in terms of labs, comorbidities. So patients could have an ejection fraction as low as 40%, creatinine clearance as low as 30, and an ECOG performance status as high as 2 to be eligible for this study. Again, you see quite favorable objective response rates, and over half of patients had a CR. Similar to what we see with the other studies, those patients who have a CR as designated in this orange color tend to have much more favorable progression-free survival and overall survival, suggesting that the goal of therapy with CAR-T should be to achieve a CR because you're more likely to maintain that remission with a deeper response. We've looked at how these cellular therapies perform outside of a tightly controlled prospective study. Some of the initial patients treated across the US were captured in this US cohort. This is nearly 300 patients treated with commercially available axi-cell, since it was the first approved for adults with large cell lymphoma. And among these 298, the majority who never made it from cell infusion or to cell infusion were due to progressive lymphoma, though you do see small numbers of other reasons why patients may not make it from collection to cell infusion. And when we looked at the toxicity profile, it was among 275 patients across 17 centers in the US. When we consider the characteristics of these patients versus those enrolled on the prospective ZUMA-1 study, there are some important similarities. Very high success rate in terms of successful manufacturing and infusion of cells, though there were a larger number of patients with poor performance status, including nearly 20% that had an ECOG of 2 or higher. Fewer actually refractory or primary refractory as compared to the ZUMA-1 study. As a result, slightly higher percentage who'd had chemosensitive disease at one point. We were able to look at the various subgroups of large cell lymphoma, and again, you see overrepresentation of those poor risk groups, including double or triple hit or double expressors. Importantly, these patients don't look like the prospective cohort in terms of comorbidities, with 43% of patients would have failed to qualify for the ZUMA-1 study, and include among these, 40% would have failed due to multiple eligibility criteria. And we just listed some of the most common reasons, which include performance status that was less good, cytopenia, such as thrombocytopenia, platelet count less than 75,000, having had a recent blood clot in the last 6 months, and including over 20 patients that had a history of CNS involvement with lymphoma. Not included in those reasons why patients would not have qualified for the study, we also see some deviation in practice in that over half of patients were bridged. So bridging therapy is lymphoma-directed therapy between the time of leukapheresis to cell infusion, despite having a sort of vein-to-vein time of 21 days, which compares quite favorably with the prospective study. Again, most clinicians felt that the patients with active lymphoma needed to be stabilized while awaiting manufacturing, and the type of bridging strategies employed here. we can't really conclude that one bridging strategy is better than another. The numbers were quite small. And in general, there is debate as to whether or not bridging is worth pursuing, yes or no. Part of the challenge is when you look at the outcomes among those that are bridged versus those who are not bridged, we bridge the worst patients, meaning these are patients with worse performance status, and more likely have advanced stage disease, high risk IPI, bulky disease, LDH that's greater than the upper limit of normal. And again, many of them would have failed to have qualified for the Zuma 1 due to multiple reasons, but likely reflects rapidly progressing disease that starts to impact performance status and organ function. When we look at the safety across this real world cohort, again, despite being quite different in terms of baseline criteria, fortunately, we see comparable rates of grade 3 or higher cytokine release syndrome and ICANS. However, that's at much higher utilization of tocilizumab, which is an IL-6 blocking agent, and corticosteroids. I think this reflects the evolution of practice patterns. We've gotten much more comfortable intervening earlier in the acute toxicity phase, including as early as grade 1 that's persisting 72 hours or more. And that likely reflects the much higher use of mitigating strategies. But again, fortunately, safety does not appear to be worse. When we look at characteristics that may predict for higher grades of toxicity, because I do think that would be helpful, inflammatory markers at day 0, peak levels of CRP and ferritin do associate with higher likelihood of having grade 3 or higher CRS or ICANS. And likely there is a component not only of underlying inflammation, but also tumor burden, as higher amounts of lymphoma also generally result in higher levels of CRP and ferritin. When we look at the toxicity across age groups, fortunately, we don't see significant differences, at least in CRS, for patients that are less than 65 versus those that are 65 and older. Maybe slightly higher rates of grade 3 ICANS. Fortunately, again, the utilization of tocilizumab steroids in ICU was quite comparable. And the outcomes in terms of PFS and overall survival, again, are quite comparable, suggesting that at least with an age cutoff of 65, you should not use age and isolation as a reason not to pursue CAR T-cell therapy, because the safety and efficacy looks to be quite comparable across these two age groups. When we look at clinical features that may help us identify good and poor risk patients, two of the most robust factors that we found in our data set, but have also been observed in CIBMTR data sets with now over 1,000 patients sized cohorts, LDH at baseline and performance status were robust factors in terms of association with both PFS and overall survival. Now, part of the challenge is I do think these are likely surrogates of rapidly progressing lymphoma. And so do we not pursue CAR T in the setting of a patient with an LDH that's greater than the upper limit of normal? Not necessarily, but what it does help in is counseling patients and maybe even exploring the sequencing of therapy. And as we have potentially more options now in that relapse setting, timing CAR T may be at least considered when you know patients are going into this with poor risk features. What about longer follow-up? So at ASH this year, we showed 3 years of follow-up. And again, despite quite a bit of baseline characteristic differences between our commercial CAR T cohort and Zuma 1 cohort, the outcomes, again, look to be very favorable, even with longer follow-up, with, again, 2/3 of patients still without an event at 3 years of follow-up. PFS, again, looks to be very similar, with over 40% of patients still remaining without relapse or death at 3 years of follow-up. One of the other issues that has emerged in terms of late toxicity, because we spent a lot of time talking about cytokine release syndrome and ICANS, which generally happens within the first 30 days and is generally managed at specialized centers who are, in my opinion, are getting much better at intervening and managing patients through this acute phase. But there are late toxicities that are also worth discussing. And prolonged or persistent cytopenias appears to be one of the more challenging situations, particularly in the COVID-19 pandemic, because this potentially then puts patients at risk for infection for sometimes months to even years. In our cohort of patients, we saw that grade 3 or higher neutropenia beyond the first 30 days is an issue for at least 10% of patients. 9% have grade 3 or higher thrombocytopenia that persists. And then about 6% of patients will have at least 2 lines that are grade 3 or higher. And you can see the breakdown in terms of neutropenia, anemia, thrombocytopenia at 12 months, 24 months, and 36 months. Unfortunately, as we get further out, generally counts do improve or recover, but you still see a number of patients out here, even at 3 years out, with persistent cytopenias. We've also looked at second cancers now with longer follow-up. And we do see about 7% of patients will have a second malignancy beyond just the large cell lymphoma that led to axi-cell infusion. When we look at treatment-related, either MDS or AML, we did observe this in 12 patients, or 5% of the study population. And you can see the majority were MDS, with 1 patient having AML and 1 with CMML. In terms of the other types of second cancers, it's kind of a number of different solid tumors. Skin cancers, again, appear to be one of the most common. I alluded to this. There are other real-world cohorts, including the CIBMTR is reporting a number of analyses at the last few meetings. This looks at the real-world experience with TISA-cell or tisagenlecleucel in larger number of patients, about 366 in this cohort. And they looked at those that, again, would have been eligible for Juliet, the prospective phase 1/2 study, versus those that were ineligible. Unfortunately, the outcomes look to be very similar. And as we saw in the prospective study, for those patients who achieve a complete response, generally that's more durable. In a cohort of patients at 8 academic centers in the US that had both access to axi-cell and TISA-cell, one interesting question is, how do you choose when you have more than one FDA-approved product in the same setting? This was 260 patients. Axi-cell was prescribed almost 2 to 1 over TISA-cell. Some of that has to do with manufacturing availability. But despite those differences in the baseline characteristics of these patients, the outcomes appear to be very favorable, at least in terms of acute toxicity, as well as PFS and overall survival. Not a statistically significant difference. You do see a little bit of separation occurs with the PFS of axi-cell appearing to be slightly more favorable, at least numerically, than TISA-cell, but overall survival is absolutely no difference. And the duration of response among the responders also appears to be similar. So I'll suggest that people are generally applying clinical characteristics, at least in terms of frailty, comorbidities, disease tempo, whenever they have more than one construct available, with axi-cell having likely the most reliable manufacturing and the shortest turnaround time, but also higher rates of ICANS or cytokine release syndrome. Therefore, axi-cell is generally preferred for patients with aggressive disease that's progressing quickly and they're young enough to tolerate the toxicity. What about CAR-T in second line, where there were 3 randomized studies that have read out and been published in the past year, looking at the 3 FDA-approved products in the third line or later setting, moving it into second line for a specific population of patients. So these are patients that were refractory to frontline, so either failing to respond, progressing on frontline treatment, or progressing within 6 months of therapy, or those patients that relapsed within 12 months of treatment. And that's based off of the observation from the CORAL study that patients that progressed within 12 months of a rituximab and anthracycline-based chemotherapy, only 20% of those were successfully salvaged with platinum-based chemotherapy and consolidated with high-dose therapy auto transplant. So that was the population that all 3 studies tackled. There were key differences in the study designs and how quickly patients were infused with CAR-T on the experimental arm, which I'll walk you through some of that. But we do know that 2 of the 3 studies suggest that CAR-T in second line, at least with axi-cell and lyso-cell, For patients that progressed within 12 months of frontline anthracycline-based chemotherapy and would have been considered appropriate for salvage chemo high-dose therapy, because that was the randomization or the control arm, that you do see a significant improvement in event-free survival with axi-cel and liso-cel. But interestingly, with tisa-cel, there was absolutely no difference. And again, the median PFS, EFS was about 3 months versus about 2 months with the control arm in the other two studies. So why would we have 3 trials done in this similar patient population, all 3 exploring CAR T versus salvage chemotherapy, but have 2 studies that are positive and 1 that's negative? Well, I think it's important to recognize there were some key differences among these studies, not only in terms of how many high-grade lymphomas. So Transform had nearly a quarter of the population were double or triple hit, which we know can have quite poor outcomes. Again, differences in terms of how many patients were primary refractory versus just relapse within 12 months. Bridging, pretty significant differences in terms of how bridging was handled. ZUMA-7 did not allow for any bridging other than dexamethasone. Belinda, you could have 2 or more cycles of bridging chemotherapy if you were randomized to the CAR T arm, and the Transform, you could have 1 cycle of salvage chemotherapy if you were randomized to CAR T. You can see much higher utilization of bridging in the Belinda study. But I think probably the key difference is the median time from enrollment to cell infusion. We know that delays matter, and I think this is probably the biggest issue why the Belinda study was a negative trial. It's 57 days from enrollment to cell infusion on the experimental arm. And again, large portion of those patients had more than 1 cycle of bridging salvage chemotherapy, and that may have contributed to differences in outcomes. The other key difference was when they identified an event and whether or not crossover was used. So Belinda and Transform allowed for crossover, whereas ZUMA-7 didn't. But again, there were differences in terms of when you would consider event and allow for crossover. Here's that issue in terms of delay. It was slightly shorter in the US population versus outside of the US in terms of again, manufacturing time, manufacturing availability, but I do think that this delay in general was much longer than particularly what we saw in the ZUMA-7 study, and likely contributed to worse outcomes on the Belinda trial. So as of right now, we do have 2 FDA-approved CARs in second line for patients that progress within 12 months, and that's axi-cel and liso-cel. We don't have access to liso-cel yet. In terms of scaling up, we anticipate we might have access to it in second line as early as September, but right now we do have access to axi-cel in second line. What about moving it into even earlier lines of therapy? So Dr. Nilapu conducted or led the ZUMA-12 study and is now published and has led the way for a randomized trial that's just started. But ZUMA-12 took patients with high-grade B-cell lymphoma, again, having MYC and BCL2 or BCL6 or all 3, and they had to have or an IPI of 3 or higher with an interim PET that showed a Deauville score of 4 or 5. Now, there's a lot of controversy regarding this criteria for enrollment, the Deauville 4 or 5. The problem is Deauville 4 could actually imply or capture patients that have had a dramatic interim response to frontline chemotherapy, and you don't know if those patients would have gone on to do well or not. And the positive predictive value of an interim PET is only about 30%. So that's one potential limitation of this study, but this really was more of a pilot or hypothesis generating study to really explore how early can you administer cells. So this is after 2 cycles of therapy in the single arm phase 2 study. Importantly, the expansion, the fitness of these cells appears to be more favorable even than what we see with the ZUMA-1 cohort, because these patients are much less heavily pretreated, and the outcomes look to be quite favorable with 85% objective response and 74% achieving a complete response. Relatively short follow-up for this study, but it does appear that, again, the initial responses appear to be quite durable. This is the duration response and progression-free survival of ZUMA-12, again, looking at axi-cel as a single infusion after 2 cycles of frontline anthracycline-based chemotherapy for those patients who still had a Deauville score of 4 or 5. So as a result, the Zuma 23 trial is launching now, looking at Axi-cel versus continuing chemotherapy for patients who've had at least one cycle of frontline anthracycline and plus CD20 antibodies. So, it'll be some time before we hear the results of the study, but a randomized trial will be the best way to know if Axi-cel will potentially move even into frontline. So how do we currently approach large cell lymphoma? Well, we didn't talk about it today, but the POLARIX study suggests that polatuzumab replacing vincristine in frontline might move into frontline for at least some patients with large cell lymphoma. And then depending on when patients relapse, so if they relapse within 12 months, we do have Axi-cel and now Lyso-cel potentially starting as soon as September. For patients who relapse beyond 12 months, we're still pursuing salvage chemotherapy, and for chemo-sensitive patients, high-dose therapy, auto transplant. But we also have tafasitamab, which is a naked CD19 antibody in combination with lenalidomide for those patients who are deemed late relapsers, but poor candidates for intensive therapy. This does raise a question, though, of how do we sequence CD19 directed therapy and what is the impact on later lines, which we don't know the answer to that yet, but it's still an option. And for third line, for patients who fail, who still CD19 positive, we do have CAR T-cell therapy. There are other therapies underway. So the pilot study just got published, which looks at Lyso-cel for patients who relapse later than 12 months and are not candidates for high-dose therapy auto transplant. Bispecifics are moving into second line in combination with salvage, and we've got a number of targeted agents in later lines. I'll shift gears a little bit now and talk about CAR T outside of just the large cell lymphoma or aggressive lymphoma space. The ZUMA-5 looked at Axi-cel for the treatment of relapsed refractory follicular or marginal zone lymphoma. There was a small cohort that included marginal zone, and it did include grades 1 through 3A. They had to have had at least 2 prior lines of therapy that included an an alkylator and CD20 antibody. I think this is the challenge we're all facing, is who's an appropriate candidate for CAR T among the patients with indolent lymphoma, where it's perceived to generally not be as great of an unmet need in terms of novel therapies. And we also weigh the toxicity equally in terms of efficacy for these patients who are otherwise facing quite favorable outcomes. But among this cohort of follicular marginal zone lymphoma patients, you can see the follicular was much larger number than the marginal zone lymphoma patients. We see very high objective response rates. Nearly 80% of the follicular patients achieved a complete response with a one-time infusion. I think that's worth noting. Now, the downside is they do have to have lymphocyte depleting chemotherapy, which consists of cyclophosphamide and fludarabine for 3 days. And many of these patients are hospitalized for monitoring for acute toxicity. So though it's a one-time infusion, it's generally, I counsel patients, it's about a 6-week endeavor. The PFS looks to be very favorable, as does overall survival, particularly for those patients with follicular lymphoma with a median PFS of nearly 40 months. And these are quite heavily pretreated patients who'd had at least, most had had 3 prior lines of therapy. It's hard not to look at the marginal zone lymphoma curves in this PFS and OS estimates and be disappointed. In the median PFS for the marginal zone patients is only 17 months. Again, I do think there are some differences in the biology of follicular and marginal zone lymphoma, though we tend to lump them together in studies, and it is a small cohort. But as a result of this, we currently did not have approval for marginal zone lymphoma, only follicular, based off of the ZUMA-5 study. When we look at the forest plot at the various sort of baseline characteristics, most subgroups tended to benefit from Axi-cel, including those patients that had failed prior cell mods and PI3 kinase inhibitors. The problem, though, I think, is potentially still the safety. So about 15% of patients with follicular lymphoma still had grade 3 or higher neurotoxicity. It was even higher among those with marginal zone lymphoma, which is also why it's not currently approved for marginal zone lymphoma. And then those that had cytopenias persisting beyond 30 days that were grade 3 or higher were in about a third of patients. And so I don't take this lightly. I think it is potentially a challenge, particularly as the number of treatment options for these patients is quite broad. But I do think this opens a door for potentially safer CARs. So the ALARA study looked at TISA-cel for the treatment of relapsed follicular. There was no marginal zone lymphoma patients in this study. Similarly, they had to have had at least 2 prior lines of therapy that included an alkylator. Interestingly, they allowed for bridging, and over half of patients received bridging, which I think is also interesting, because generally we don't think of follicular lymphoma being one that patients can get in trouble in that 3 to 4 week time span of needing or awaiting manufacturing. Nonetheless, probably speaks to the fact that these were more aggressively behaving indolent lymphoma patients that were considered for CAR-T. When we look at the responses in PFS with TISA-cel, they look to be quite favorable with a median PFS of nearly 30 months with TISA-cel. Interesting in this subgroup analysis, those patients who had 5 or more lines of therapy, high metabolic tumor volume, or POD24 status did not do as favorably with TISA-cel. This at least suggests you might potentially want to use this in earlier lines in a setting with less tumor burden to try and select out patients with more favorable outcomes. So we have 2 FDA-approved products for the relapsed refractory follicular lymphoma population, though I would say uptake has been rather slow, probably just the competing treatment landscape, and also the fact that many of these patients are going to do well with their first 2 lines of therapy. So again, finding patients in that 3rd line or later space is becoming more challenging. The ZUMA-2 looked at KTE-X19 or Brexacel. So this is similar to Axi-cel in that it's a CD28 co-stimulatory molecule. The difference is during the manufacturing process, the leukapheresis product is purged of any CD19 positive cells, including lymphoma cells. And the rationale behind that is mantle cell lymphoma, for instance, frequently will have circulating tumor cells. And so if you have contamination of your product with lymphoma cells, that may trigger activation of those CARs and even more T cell exhaustion in the product. And we know T cell fitness is important in terms of efficacy. So it's just a different manufacturing process. They also did the studies differently. So they did allow for bridging in the mantle cell lymphoma cohort that included option of a BTK inhibitor or dexamethasone. You get similar lymphocyte depletion. It is still a one-time cell infusion, but they also capped the number of prior lines of therapy, and they allowed for patients who'd only had 1 prior line of therapy. So this is a different sort of approach than what we've seen with Axi-cel and follicular and large cell. Duration response, PFS, and overall survival, again, look to be very favorable with Brexacel in relapsed mantle cell lymphoma, and similar to what we've seen with other CAR-T studies, those patients who achieve a complete response, more of them will remain in remission. The Transcend cohort looking at Lysa-cel for relapsed mantle cell lymphoma has been reported out. Again, similar to the larger Transcend study, the lymphocyte depletion is fludarabine and cyclophosphamide with slightly lower dose than what we see with Axi-cel products. And as I mentioned previously, more generous eligibility criteria. Patients had a prior BTK inhibitor, and if they'd had a prior allo or auto, they were eligible if they otherwise met eligibility criteria. So looking at the data that's been reported thus far, these are just the mantle cell lymphoma patients. And again, you can see quite favorable responses that do appear to be durable, at least for those patients who have longer follow-up thus far. So we have FDA approval for Brexacel for relapsed mantle cell lymphoma. I think the challenge is the label's pretty vague. It only says relapsed mantle cell lymphoma. The study was mostly done in those that had failed a prior BTK inhibitor. So I would say most places in the US are using CAR-T for patients in 3rd line who have failed usually a frontline chemotherapy plus CD20 antibody and then 2nd line BTK inhibitor. There are studies underway, I will mention, that looking at CAR-T in those P53 mutant or high risk patients that you might want to use CAR-T in even earlier lines of therapy, potentially even as soon as similar to what was done in ZUMA-12 after 1 or 2 cycles of chemotherapy. So those trials are all underway. There's a growing unmet need, though, now to address those patients that fail anti-CD19 CAR-T About a third in the lymphoma space. This is different from the ALL space, but in lymphoma, only about a third lose CD19 as a mechanism of resistance. And so there are strategies to try and address this. One issue is, well, what if there's a pre-existing CD19 negative clone, and just through selective pressure, that's emerging as the dominant clone? One strategy to address that would be to have a dual antigen targeting CAR, and those bispecific CARs or dual CAR studies are underway. We have one at Anderson looking at CD19 and CD20. There's CD19, CD22 CARs that have been tested and even published by the Stanford group. I would just say that's probably the less frequent cause of failure. 2/3 will have CD19 positive relapse. And so how are we addressing these? One issue is the intrinsic T cell dysfunction. So we know that T cells that are more exhausted or are less immature in terms of the phenotype tend to do are associated with less favorable outcomes. We're starting to see this emerge, particularly as CAR T moves into earlier lines of treatment. And it's one of the strategies underway with Novartis right now to shorten their manufacturing time. So they have their YTB2323, which is essentially T-cell with a much shorter manufacturing time in selecting out more stem-like phenotype for their T-cells to manufacture the CAR in. And then there's the microenvironment is also potentially challenging. I think a lot of this is driven by the tumor biology, but nonetheless, can we look at combination strategies with checkpoint inhibitors to try and overcome that? So I'll briefly cover some of the strategies that are underway. One option is just to use a healthy donor T cell. So there are a number of allo CARs that are being explored. Allogene has one unique approach to their allo 501 or 501A, which is they knock out the native T cell receptor. They also knock out CD52 and then introduce their CD19 CAR with their co-stimulatory domains. But because they knock out CD52, they also have an anti-CD52 antibody that they use in their lymphocyte depletion. Because the challenge with all of these allo CARs, you can improve the fitness of the T cells, but how do you address the persistence and essentially help shield these cells from the patient's own immune system? So most of the strategies are looking at intensifying the lymphocyte depletion, or in this situation, adding a CD52 antibody. We've seen, again, preliminary data, small numbers, but thus far it looks like the toxicity is more favorable with these allo CARs. And as a result, because persistence is probably still limiting this in terms of being able to replace the auto CARs, there are strategies looking at more than one infusion. And I think one maybe advantage of the CD52 antibody that the Allogene company is using is that may allow for repeated infusions of allo CARs without having to repeat the lymphocyte depleting each time. But these are all questions that are persisting. We do see some patients, again, small numbers, some do appear to have some durable responses, but I would say right now the majority are potentially failing within that 3-month window. And so that's where this is still preliminary. We have another allo CAR, I think there are many others, but CRISPR has now opened the opportunity to be a little bit more efficient and maybe even creative in terms of how you might manufacture CARs. So Caribou utilizing CRISPR technique is not only introducing an extracellular CAR and knocking out the native T cell receptor, but they've taken it a little bit a step further. They're also knocking out the gene that codes for PD-1 to potentially address the microenvironment triggering exhaustion or putting the brakes on these CARs penetrating into these tumor sites. And so we presented the preliminary findings of this CB10, which is an allo CD19 CAR with the CRISPR technology to manufacture and gene edit. Dose level 1 was 40 million cells. Again, a little bit higher lymphocyte depletion based off of strategies developed at the NCI in the melanoma TIL world. And so it's 60 mg per kg per day for 2 days of cyclophosphamide and then 5 days of fludarabine. But it is a one-time infusion of this CB10. We've only presented the first 6 patients at the EHA meeting. But you can see cytopenias are one of the most common toxicities. Only 2 patients have had CRS and 1 patient with ICANS thus far, in small numbers. And we look at the ICANS, the median time to onset was 8 days. It resolved within 2 days, and the median time to onset of CRS was 4 days. Because of the more aggressive lymphocyte depletion, infections is another important AE of special interest. And we do see at least 1 patient with grade 3 septic shock that did fully recover. It's early, but we are seeing at least 3 of the 6 patients having CRs that are persisting beyond the 3-month window. The interesting thing as well is all 6 of the first 6 patients actually achieved a complete response. Now it's different subtypes. Some are less heavily pretreated than others, and it's still early, but again, suggesting that the allocars, as we get better at refining the lymphocyte depletion and with the opportunity of CRISPR to further gene edit, that might potentially address the unmet need of getting healthy, effective T cells to patients faster than what we can do with auto CARs. What about using a different cellular therapy altogether? Well, NK cells have some potential advantages over T cells. Potentially the absence or very low risk for GVHD, the toxicity profile, so very low rates of CRS and probably low to no concerns about ICANS make this a potentially attractive option. So our group, Katie Rezvani and EJ Spall, used cord blood derived NK cells and a retrovirus to introduce the extracellular CD19 CAR, similar fludarabine cyclophosphamide LD, and then one-time infusion of these NK CARs. As a result of the MD Anderson phase 1 study, which had a very favorable safety profile, essentially 1 grade 1 CRS, no ICANS observed, and about 36 patients treated thus far. That led the way for the multi-center phase 2 study of TAC-07. It's now been licensed by Takeda and now has a cryopreserved formulation. And so still in dose escalation, starting at 200 million cells versus 800 million cells. And this study's just started, but will help us understand if there's going to be a role for NK CARs. And then the Fate Therapeutics group, they also have an NK CAR, slightly different approach. So they have the IL-15 receptor fusion and the non-cleavable CD16, all in attempts to try and improve persistence. So I think one of the challenges with the NK cells, even probably a greater challenge than the allo CAR Ts, are the persistence. But fortunately, again, the toxicity profile looks to be very favorable. So this is the Fate 596 NK CAR. You can see again, very low rates of CRS, no ICANS observed thus far, and infection likely related to the lymphocyte depletion. So we don't have, again, large number of patients, and there is dose finding, and with the Fate Therapeutics, they're combining with rituximab, so you can't really compare across these studies at all, but it's at least good to see that we are seeing objective response rates with these non-CAR T cellular products. And the last thing I'll end on, because we're all excited about this and talking about it, are the bispecifics. So these are CD20, CD3 bispecifics that are being developed in B-cell lymphomas that will likely directly compete with CAR T for a number of reasons. One, they're more readily available. They're off the shelf. You don't have to manufacture. And the objective response rates look to be quite comparable. Now, they're not quite as good, in my opinion, as what we see with the single infusion of an auto CAR, but they compare quite favorably, particularly with the allo CARs. And you can see, again, over half of patients with epcoritamab or glofitamab achieving objective response rates. Mosunetuzumab, probably one of the lower responses in large cell lymphoma, specifically the very high rates in follicular lymphoma. And I think what's important is we are seeing responses in the post-CAR T failure. So many of these patients had 20 to 40% of their population having failed a CAR. So likely first introduced into that 3rd line or later space, will be heavily used in the post-CAR T failure patient population, but will probably also move into earlier lines. And I anticipate we'll have potentially even broader uptake than the CAR just because of the availability. So I'll conclude that CAR T-cell therapies clearly transform the management of chemorefractory large cell lymphoma. It is underutilized, probably the result of the cost, the requirement to refer patients to specialized centers. So access is still an issue in the US. And I think the perceptions regarding toxicity, in my opinion, we're getting much better at managing the cytokine release syndrome and neurotoxicity. We probably need to spend a little bit more time educating and understanding the cytopenias and the second cancers and how to address those. Though fortunately, the rates of toxicity that result in death are quite low. I do think that CAR T should have a place in second line, particularly for those early relapse patients, because in my opinion, axi-cel and liso-cel were far superior to salvage chemo and auto transplant and should replace salvage chemotherapy in second line for those early relapse patients. For late relapse patients, we don't know the answer to that. I still am pursuing salvage chemotherapy for those who are appropriate candidates for intensive therapy. And if they have a CR, moving on to high dose therapy auto. It's just in my practice, that's the minority of patients. I think the questions about CAR T beyond just large cell lymphoma are how do we identify appropriate candidates? Clearly, the efficacy looks to be very favorable in follicular lymphoma. The problem is there are other options that are also probably quite good. And so how do we identify high-risk patients? In my practice, it's those that are progressing quickly through treatment and are young enough that they're going to benefit potentially from a therapy that is a one-time infusion and can give them several years of remission. In mantle cell lymphoma, we are using CAR T in those post-BTK inhibitor failures, and I do think it's an effective strategy, but once again, access is an issue, and so probably underutilized. And future directions will include whether or not we can improve the T-cell fitness, and that translates into improved efficacy with using healthy donor T-cells, maybe even NK CARs. I think the durability is still the question. And as of right now, it's still early and only available on clinical trial. I do think the bispecifics will be disruptive, but I think it will be complementary and it will be good for patients to have more options. And so we might potentially be able to optimize patients by giving them a bispecific, either to decrease the amount of disease prior to going to CAR T or post CAR T failures. And with that, I'm happy to answer any questions.
Thank you, Dr. Loretta, for that wonderful coverage of this subject and updating us. It was beautiful, very, very educative. So I'll ask the Indian faculty to use raise hand sign and ask questions to her. Meanwhile, there is a question from audience. There's a question from Dr. Sanjeev. What is the role of stem cell boost as prophylaxis to avoid severe neutropenia and infections after CAR T cell therapy in relapsed refractory DLBCL?
Yeah, it's a really good question. I think we are asking and applying that a little bit more in our myeloma patients. And the reason why I say that is the majority of patients with large cell lymphoma who are going forward with CAR in the US right now have never had an auto transplant. So again, at least probably the highest numbers I've seen is about 30%, but it's probably closer even to 20% that have ever had cells collected. So we don't generally have the opportunity oftentimes to boost them. And the other important news is only about 9% of patients will have persistent cytopenias that really put them at risk for infections or significant complications. I think there is a lot of study underway right now to understand the mechanism of the cytopenias. I think part of it is probably an inflammatory state in the bone marrow as you have B cell recovery. And so thinking through strategies in terms of, are there supportive measures that we can do beyond just growth factors to try and address this? Those studies are all underway, so it's a little too early. But in our myeloma patients that have, again, stem cells available, if they have cytopenias, we are, at least my myeloma colleagues are pursuing that a little bit more regularly than we are in lymphoma.
Thank you. One more question from audience. Dr. Prem, are CAR T therapy options better than loncastuximab or tafasitamab with immune modulator, with or without other synergistic therapies?
That's a really good question. We don't know the answer to that because the only randomized studies thus far have been CAR T versus salvage chemotherapy. I think in general, at least in our practice, tafalin, lonca are generally utilized for those patients that are frail or worried about them being able to tolerate the toxicity of a CAR or are post-CAR T failure. So I don't have a good sense how they would compare in the same patient population because they're being utilized in different patients. And I don't think any company is ever going to take on a tafalin versus CAR T trial. So we may not ever know. But there will be more real world data emerging in terms of how tafasitamab performs outside of the L-MIND study, for instance. And so again, I do use Lonca or tafalin post-CAR T for those patients that are still CD19 positive, or in second line, I might use tafalin for an older frail patient that I'm just nervous about getting through liso-cel, for instance.
Thank you. Dr. Sharath, your question.
Thank you, Dr. Loretta, for that wonderful talk and the data which you took us through. I have two questions. The first one is your experience with B-cell aplasia post-infusion, and did that correlate with the relapse rate subsequently? And the second part is in the lymphodepletion conditioning, is there a role to kind of add Ritux to that?
Good question. So I'll start with the first one. The B-cell aplasia definitely does occur, and we've seen it across all of the constructs. In my just opinion, it's probably greater with axi-cel than it is with tisa-cel or lyso-cel. Fortunately, it's not been associated with significant risk of infection, though we do a lot of prophylactic strategies like PJP prophylaxis. We have everybody on Valtrex for at least a year, 2 years until their CD4 counts recover. So I don't think it's a biomarker for efficacy, at least in all of the in lymphoma, I should specify, across ZUMA-1, across Juliet, and the Transcend. That's not been associated with durable responses. So we check it, but we don't act on it, meaning we're not giving everybody prophylactic IVIG, and we don't use it as a biomarker for persistence of CARs. The second question about adding rituximab to lymphocyte depletion. So Palestrati presented at EHA. There was another ZUMA study looking at adding rituximab at lymphodepletion, also at day 21 post-CAR infusion, and then there were about 4 other doses that were administered. Again, it's a single-arm phase 2 study, so it's hard to draw any strong conclusions, but the efficacy looked to be quite good. Now, it was done in a different population. They also allowed for patients as early as second line while the ZUMA-7 study was underway. So it's not the same population as ZUMA-1. So I would argue not to draw conclusions because the response rates look higher, that it's because of the rituximab. We don't know. It was done in a different patient population, but it looks good. It clearly didn't have a negative impact on toxicity. And it's reasonable to consider it, at least, as part of the pre-treatment.
Thank you.
Thank you, Sharath. One more question from audience. Dr. Rahul wants to know, does CAR T cells help in CNS relapses?
Yeah, that's a growing area of interest. So the folks in Boston have a small cohort looking at tisa-cel for CNS lymphoma. It's a small cohort. It's hard to draw strong conclusions, but at least among, I think they had about 7 responders out of their original 18 planned patients. And so it looks like there is a signal there. We had looked in our cohort of 298 patients and had about 20 that had a history of CNS lymphoma. Most of them didn't have active CNS disease when they went in, but we did have a couple, including one at Anderson, who ended up having a pretty significant stroke in the first 7 days post-infusion. Now, again, whether or not that was a manifestation of neurotoxicity or if it was the fact the patient had active disease going in and had cells, penetrating into that space, we don't really know, but patient did well from an efficacy standpoint, but then had some debilitating issues from the stroke. And so as a result of that, our practice is to go into it with stable CNS disease, meaning no active seizures. We would really like to have the CSF fluid cleared of circulating lymphoma cells, but we are exploring that with our commercial CAR. The problem is most of the studies exclude these patients with the exception of the Transcend study, but even on the Transcend study, it was only about 7 out of the 300 and so patients. So we don't have a ton of prospective data, But at least in our retrospective series, it looks like it's a reasonable consideration for the right patient.
Thank you. Here's one more question. Do we check the intensity of CD19 in lymphoma? And if there is DIM expression, does CAR-T still work?
Yeah, so that's a really interesting topic. And actually it was either at ASCO or EHA, there was a poster talking about the criteria that predicted for response on Zuma 7. And one of the things that is sort of counterintuitive, but having high CD19 expression, which is an H score, was actually associated with less favorable outcomes than low CD19 expression. So I just mentioned that because I think it's messy. For patients who've not had prior CD19 directed therapy, none of the studies suggest that you had to have a certain threshold of CD19 expression to have efficacy. But just the fact it's a B-cell lymphoma, we would expect there is some CD19 expression, maybe even at very low levels. The question though, now that we have things like TAFA and LONCA, where you may have some selective pressure against the CD19 negative clones to emerge before CAR, we are testing for CD19 expression in those patients who've had TAFA-LIN prior to CAR, and we do want to see some expression present, but I don't think that you have to have a certain threshold or level to have confidence in the efficacy of CAR. And if they've never had CD19 directed therapy, I don't worry at all about the CD19 status.
Thank you. Dr. Shweta, you have a question?
Very nice talk. Thanks for a very lucid presentation. So my question is, what is the, how much is the tumor burden which is acceptable for CAR-T cell? When we talk about the refractory and relapse cases, they have very high tumor burden. So is there any eligibility criteria in your trials, or how you decide which patients are good to take for the trial?
Yeah, so that's probably the hardest thing we're debating right now. So the problem is, if you look at tumor bulk as defined by having a certain sized lymph node, whether it's over 7 centimeters or over 10 centimeters, those features never have been strongly associated with efficacy. They have been associated with toxicity. So we definitely know you have higher rates of CRS and ICANS if you have higher tumor bulk going in. But there's been a recent analysis, now we have 5 years of data of Zuma-1, the higher bulk patients, even though they had no association with response, it clearly did predict for less long-term remissions. And so if you had higher bulk, you would respond, but you were more likely to lose that response over time. And so we're becoming more aware of that. I think the challenge, so none of the studies will exclude them, but I do get a little bit nervous about patients with bulky disease. But as you mentioned, these are all patients who have failed at least 2 really good lines of therapy. And so what's a third line that I can debulk them before I move to CAR-T? So we've been exploring radiation in certain patients, and I do think that is one strategy that helps us. And we're not trying to do definitive radiation treatment. We're giving 12 gray to try and reduce that bulky disease while we're manufacturing. I think that's one strategy that could be explored. I think if you have a disease that's rapidly progressing, there's no CAR that's going to overcome that. And that's probably why some bulky tumors are not rapidly progressing. They've been bulky, but they've been relatively stable. And so that's why I think the bulk question is probably not played out very well in terms of our retrospective or our multivariable analyses. But those patients with rapidly progressing tumors, that's usually those where the LDH is starting to skyrocket, performance status is starting to drop pretty quickly. Those are the patients that I get nervous, and I will either pursue something else or hold off on CAR.
Thank you so much. One more question. You talked and you just touched about the CAR NK cell therapy. So what do you think? What will be the future? Will there be CAR T cell therapy or CAR NK cell therapy for the lymphomas? Because that's the off-the-shelf therapy, and it may be more useful.
Yeah, I think there's a lot of optimism surrounding the off-the-shelf therapies for 2 reasons. But probably the most important thing is they're readily available. So we know that even in the Belinda study, there was a large portion of patients that never made it from cell infusion or collection to cell infusion on the control or the experimental arm. Even with Axi-cell in our real world experience, about at least 12% of patients, you have issues getting them from collection to cell infusion. And these are all the patients that have actually undergone collection. What about all those that never even make it to collection? So there is a huge unmet need to getting these therapies available to patients faster. And so the allo products clearly have an advantage there. The safety, in my opinion, looks a lot better. You just have far less CRS, and again, hardly any, if I would expect no ICANS from the NK CARs. And with the allo CAR Ts, you have very low rates of CRS and ICANS, which is intriguing to me. So you have it more readily available, it's going to be less toxic. The challenge though right now is all hinging on durability. None of them look as durable as the auto CARs right now. So then the question is, well, would we ever use them as sort of a bridging strategy to get them to an auto? The problem is, at least in my limited experience, the patients who fail them don't respond to an auto either. And so I do think you kind of have one shot with a CAR. I don't think repeated infusions or giving an allo NK CAR and then following with an auto CAR later is going to be an effective strategy. So I think we're all just kind of waiting to see if the durability is going to hold up or at least challenge the auto. If it does, then all of us would probably use an allo. If it doesn't, then we're probably still going to be using autos.
Thank you, Shweta.
Thank you.
Similar question from the audience. Can we do CAR T cells twice?
Yeah, I don't think so, but I could be wrong on that. It's still really early. Almost all the allo products, they're exploring that as a strategy to improve persistence. Part of the problem though is you probably do develop some immunity too. And so if you have to repeat, so the first question is, well, why did they fail? Did they fail because the tumor biology is really bad and the microenvironment is very toxic to cellular therapy? Or is it just you didn't get enough dose? And so I think repeated infusions might help with the dosing question, but I don't think it's going to address the microenvironment or the biology of the tumor. So I think that's part of the problem is the way we're using them. We're using them in patients that are failing, and we're hoping that another infusion is going to overcome that. And so far, that doesn't appear to be true.
Thank you. Rahul has one more question. In DLBCL, is the response different based on the cell of origin?
No, we haven't seen that yet. There's some data that has emerged from Moffitt that things, and I think MSK as well, poor biology such as P53 mutations, complex cytogenetics, those tend to predict for less favorable outcomes. But so far, cell of origin has not.
Thank you. So we have Dr. Hari and Dr. Gaurav here who have raised hand. Hari, your question.
Yeah. So something similar to just what you answered about aggressive relapses and about the utility in double hit lymphomas. And we know that when you have early relapses, aggressive relapses, even for any salvage regimens they don't do, does CAR T cell therapy overcome that to a certain extent? And my second question is, what about post CAR T cell therapy? There are concerns about the need for using immunoglobulin therapy subsequently. And in your experience, has that requirement come down, or is it because that adds significantly to the cost burden for managing a patient subsequently?
Yeah. So good question. So the first question I think is a really fair criticism of the randomized phase 3 studies, and probably Belinda helped shed some light on that more than the others. It did select out very good risk patients, right? I mean, you had to get onto a trial at a treating center, be able to just receive 40 milligrams of Dex for 4 days if you were on Zuma 7 on the experimental arm, and make it to cell infusion. And so that in itself is already probably a select group of patients. When we look at the Belinda study, they had much higher rates of double or triple hit or high-grade lymphoma or even refractory disease in comparison to what they had enrolled on the Juliet study. And T-cell performs less well in Belinda than it did in Juliet. And so I do think there are some large cell lymphomas that are progressing so quickly that you're going to have to try and stabilize them with some other lymphoma-directed therapy. Where I do think this is still important is you want to get the CAR as early in the line of therapy as possible. And so even if you give them one cycle of salvage chemotherapy to try and cool them off, you still want to try and get them to CAR as quickly as you can. I've heard debates about, well, let me just go ahead and continue to pursue my salvage chemotherapy because we know CAR T works in third line. I don't need to use it in second line. And I can just give everybody salvage chemo and then only take the patients that are failing to respond to CAR. That's very reasonable. I think the challenge though is the longer you put off the CAR, the less well those T cells are going to perform and the less likely you're going to have efficacy. So I would argue to use it as early in the disease course as possible, but be smart about using chemo or radiation to try and slow the disease tempo down while you're waiting on manufacturing. The second question in terms of low IgG levels and replacing with IVIG, I would say early on we were giving everybody IVIG, particularly if your IgG levels drop below 400. We've stopped doing that, and I didn't show this in our fraught with selection bias, but in our study, we looked at the prolonged cytopenias, we looked at infection, and actually patients who got prophylactic IVIG were more likely to have infections. But I think, again, that's too much selection bias. We only gave IVIG to those patients who were high risk, but prophylactic IVIG clearly did not improve their risk of infection. So we're not doing that anymore. What we will do is for patients who are having recurrent upper respiratory infections, then we might give them IVIG, but we're not routinely doing it in every patient.
Thank you, Hari. Dr. Gaurav.
Thanks a lot, Dr. Loretta. That was a wonderful talk. And a lot of the issues, questions which I had actually got covered in the discussion so far. So, but I did want to ask you, have you evolved a common or effective strategy for cytopenias, especially they're long lasting? Or do you have a stepwise approach? Or it's individualized to each patient and different strokes for different folks?
Yeah, so I think in general, there's the cytopenias, you just have to be mindful and monitor for them. What happens is you have the first 2 weeks, your counts drop because of lymphocyte depletion. And then by week 4, almost all of them have recovered. The problem is beyond week 4, they start to trail off again. And so part of the problem is everybody talks about day 30 cytopenias. Very few patients have cytopenias at day 30. Most of them have recovered, maybe not totally normal, but the problem is then the trail off that happens. And so those are the patients I get a little bit more nervous about because we don't watch them as closely beyond the first 30 days. And so that's when I generally counsel patients, and particularly folks that I'm sending back to their community oncologists. You really do have to be monitoring for cytopenias pretty closely between month 1 and month 3 for that dip off that happens again. Just depending on how low they get, we'll transfuse patients. So in my experience, it's pretty rare to have to transfuse patients. Most of the time what we're doing is giving growth factor support for neutropenia. And again, we're watching so closely for infection. And we don't repeat all of their vaccines in terms of COVID or Pneumovax until month 3. So again, between month 1 and month 3 is when we're watching really closely for those recurrent cytopenias and monitoring closely for infection. I think the challenge lies in those patients who have severe pancytopenia. And as I mentioned, it's about 6% will have more than one line down. Those are the real challenge. And I've had a couple over the years that their counts just stay really low for a long time. They're not needing transfusion, but their white count's always low. Platelets hover around 20 to 50. And so they're not really, I don't feel happy about that outcome. We're watching them closely. They're always at risk for infection. They're kind of stressed about their counts. Fortunately, there's not a ton that have treatment-related MDS, but I think that's the one thing you always have to be mindful of, and particularly when it's more than one line down. I've had a couple of them that I've diagnosed eventually with MDS. And as I showed you, we've had a few AML patients, and including a few at MD Anderson that have died from AML. And so that's the other consideration. But growth factor support, counseling on infection, and watching for signs of MDS are generally my only advice right now.
Thank you, Gaurav. A couple of questions from the audience. Dr. Abhijna wants to know, is there a correlation between grade of CRS and the efficacy of CAR-T?
Yeah, no, we've looked at that, and there's several abstracts that are going to come out at ASH this year. There's really no correlation. What's interesting is Axicell across the board has much higher rates of just all grade CRS and obviously grade 3 or higher ICANS. But when we looked at, larger cohorts of commercially treated patients with all the selection bias that applies, there's really no association with having any or high grade CRS or ICANS and efficacy with any product actually.
Thank you. Dr. Prem has a question. More than 60% of patients experiencing toxic neurological effects. And while neurotoxicity has often been described to be associated with CRS, is there any better option to control or decrease these side effects?
Yeah, that's an active area of study. So the label for Axicell has changed recently that does allow for prophylactic dexamethasone on day 0, 1, and 2. So it's essentially giving dex for 3 days, 10 milligrams, starting at day 0. The problem with, so that was cohort 6 of Zuma 1, it's non-randomized. There are some inherent biases there. So those patients had less tumor burden. They were treated in Europe as opposed to the US. So the manufacturing was slightly different. So it was not a freshly manufactured product. It was a cryopreserved product that there was an additional week added on in terms of the manufacturing time. So that probably also resulted in a little bit more T-cell exhaustion. So there's a lot of variables there that are hard to account for. But if you look at prophylactic steroids, you definitely have less ICANS with Axicell, but it's a little bit muddied. We also get a little bit nervous about giving steroids in the absence of or during the T-cell expansion time, particularly with Axicell. So as a center, we've not adopted that. But if you have a patient who has tons of disease burden and they're probably going to have toxicity, you could consider prophylactic dexamethasone starting on day 0 before cell infusion. We have a study, and others do as well, looking at prophylactic IL-1 blocking agents. The problem in my experience so far is it probably helps a little bit, but probably not a dramatic improvement, but that's another strategy that's underway. And then the constructs, like we don't see hardly any ICANS with Lysocell, for instance. And so it's really mostly an Axicell problem.
Thank you. Any more questions from the faculty?
Yes, Dr. Agarwal, if I may. Yeah.
Please.
So actually, it's with relation to neurotoxicity itself. So especially when it comes to ICANS, have you seen using steroids sometimes for a prolonged period, balancing out? How do you balance out controlling the ICANS versus any potential effect on decreasing the chance for disease clearance, effectiveness of the CAR-T? So
yes,
yeah.
Good question. So we actually have a retrospective study, which I disagree with. I think there were a lot of problems in how it was done, and no other centers have showed this. We're the only one. But we did have a retrospective series looking at the negative impact of steroids on efficacy. Again, no other centers have showed that. I think part of the problem is when we first started, the pendulum swung pretty quickly. So early on, we weren't giving anybody steroids. You didn't get steroids unless you had grade 3 toxicity. And then we realized that's probably a bad thing. So then the pendulum swung the other direction. We started giving steroids to everybody at grade 1. The problem is it's the cumulative dose of steroids, which is an issue. And this is where I do think cohort 6 of Zuma 1 does shed light, and why most other retrospective series and even prospective studies suggest that steroids are not harmful. It's how you use the steroids. So you want to start it as early as possible, but then taper it off as quickly as possible. So what we initially were doing is when we started it, we put everybody on 10 Q6 of dexamethasone, and then they stayed on 10 Q6 until we're completely back to no ICANS. Now what we do is we will start with 1 dose of 10 milligrams of dex and then just see how they do. And so as opposed to just scheduling everyone and leaving them on for prolonged periods of time, and that's what our study shows, is cumulative high dose of steroids is bad. And partly why it's bad is a lot of those patients were dying of infection, including things like yeast or fungus. And so there were competing risks of death, not just poor efficacy of the CAR. And so I don't think steroids are horrible, but I do think you should use as little as possible, and you stop when they get to grade 1. You don't have to wait till they're totally, because you'll have these lingering tremor. You'll have, with our I-score, it's pretty common for patients to keep scoring a 9 for a while, where they just miss 1, which is usually the sentence is not as legible. That can linger for a while. You don't need to be on steroids for that.
Thank you, Gaurav. One more question from the audience. What is the risk of viral infections in CAR-T infusion?
Yeah, it's probably one of our biggest challenges, actually. And so we check CMV and HHV6 antibodies before we infuse cells. If they have evidence of prior exposure, then we monitor titers every week. And we have definitely seen CMV reactivation. We've seen HHV6 infections that can cause encephalitis-like pictures. And then obviously COVID-19 has been a challenge for our patients. So we give them Evusheld, we repeat their vaccines at month 3. And so we've gotten better, I will say, at that, just because we have more options available, and the more recent variants are less likely to cause life-threatening pneumonia. And so, but yes, viral infections is clearly something we keep a very close eye on.
Thank you. Dr. Hari?
Yeah, so it's just a little bit of a futuristic question. We've never had any benefit of doing transplants in upfront setting for those whom we perceive as high risk in diffuse large B-cell lymphoma. So do you think there's going to come a time when we might explore CAR T-cell therapy in first-line therapy for patients with whom we perceive as potential for high risk for relapses?
Yeah, I think,
and that is, yeah.
Well, I could be wrong at this, but I think you need to have some antigen for CAR T to be worthwhile. Now, you want to do it at a lowest tumor burden state as possible. And so I think that's the debate that we sometimes have for those patients who have a complete response to bridging chemo, for instance. Should you still proceed with cell infusion? And my answer is always yes, because we're doing it in that 3rd line or later space, generally speaking. So how confident am I that bridging chemo cured them? I have zero confidence in that. But I think you raise an important question. What about in frontline where someone might actually be cured, but they have higher risk for relapse? Would we sort of consolidate with a CAR? Right now, probably no. That may change over time, but the reason why I would say no is it's super expensive and there's some toxicity involved. And I recognize that's true for transplants as well, but I would say it's probably harder to swallow this than it is a transplant, because in that setting, we're used to giving an auto transplant in the setting of remission. We're not accustomed to giving CAR in the setting of remission. So I think people would be a little bit more nervous about the late toxicity, the acute toxicity in that setting. So we probably won't, but I will say the Zuma 23 study is looking at using CAR T as soon as 1 line of chemotherapy, and they're trying to take on that high risk, or 1 cycle of, I should specify, 1 cycle of chemo. They're trying to take on that high risk population from the onset. So if that's a positive study, then that may change things, and we may recircle back and think about your question again.
Thank you. Any more questions for her? Okay, none. In that case, Dr. Loretta, thank you very much. You spared you a lot of time. Fantastic Q&A session, great lecture, and thanks for accepting to be with us. For the official vote of thanks, Dr. Ashish Kumar.
Thank you. Thank you, Dr. M. Agarwal. We at Zydus sincerely thank MSG and you for giving us this opportunity for supporting today's webinar. I thank Dr. Loretta for her great session today and through her session highlighting the recent updates in CAR-T. At the end of her session, she also shared CAR-T cell therapy has transformed the management of chemorefractory large B-cell lymphomas. However, cost and access still needs to be resolved for more patients to benefit. We also hope that even India will get some accessible solution very soon through the clinicians we had part of the webinar today. Dr. Loretta also shared future directions of CAR-T, and we thank her again for her session and time today. Thanks to all the eminent faculty for a wonderful discussion, and not to forget our respected virtual delegates who joined us today from not just India, but across the globe. Thank you, everyone. Good night for now. Thanks for joining in.
Thank you.
Thank you.
Thank you.